Hi, everyone. Good morning, good afternoon, and good evening. I know we have people from all over the globe today. I'd like to welcome you to our fourth webinar of our four-part series at the Center for Integration of Primary Care and Oral Health. I'm Tian Zhang. I will be your moderator today. I am a dentist and faculty at the Harvard School of Dental Medicine and investigator at CIPCOH. Today, we are doing this session together with the Harvard School of Dental Medicine Office of Global and Community Health. And we are honored to be a part of the Harvard Worldwide Week, which is showcasing the remarkable breadth of Harvard global engagement. Today, we have a fantastic panel of experts, and we will be speaking on the topic from classroom to clinic to the global community, training non-traditional oral health providers. Before we do some intros, I'd like to jump in and ask a question of you all to put into the chat. When you see the phrase non-traditional oral health provider, what type of provider first comes to your mind? The type of provider, not the person. Please type it in the chat. And I'd like to invite our panelists to also put in their first non-traditional provider as well. Community health worker, physicians, not a dentist, school nurse, fantastic. Case manager, nutritionist, behavioral health providers, wonderful. As an educator, I wanted to put you all to work immediately. So thank you so much for your contributions. Midwives, OBGYN, physician. Fantastic. So let's hold that and your answers there in our collaborative answers here, because I think this will really weave through our conversation today. So first, I'd like to give you some background around the Center for Integration of Primary Care and Oral Health, otherwise known as CIPCOH. We are a multi-institutional and multidisciplinary center supported by an award from the Health Resources and Services Administration, Bureau of Health Workforce. You can see here the institutions are the Harvard School of Dental Medicine, the Massachusetts College of Pharmacy and Health Sciences University, the University of Massachusetts Medical School, and the Harvard Medical School, along with wonderful individual collaborators, which I will show at the end of this session. CIPCOH is a national resource for systems level research with a special emphasis on training enhancements that will train primary care providers to deliver care that promotes oral health, addresses disparities, and meets the needs of all communities. We have three pillars here: research on current landscape, dissemination, and community of practice. I'd like to welcome our panelists today. We have Dr. Hugh Silk. He is a professor at the University of Massachusetts Medical School in the Department of Family Medicine and Community Health. He's also an instructor at the Harvard School of Dental Medicine and Harvard Medical School. And he is the co-principal investigator at CIPCOH. Next, we have Dr. Brittany Seymour. She is an associate professor at the Harvard School of Dental Medicine in the Department of Oral Health Policy and Epidemiology. And she is our Global Health Discipline Director at HSDM. And our third panelist is Dr. Shinam Tiku. She's an instructor at the Harvard School of Dental Medicine in the Department of Oral Health Policy and Epidemiology, and an investigator at CIPCOH and the HSDM initiative to integrate oral health and medicine. So let's jump into our conversation with our panelists. Okay, well, welcome Dr. Silk, Tiku, and Seymour. I am really pleased to see the participation of our attendees today and putting in who they think their non-traditional oral health providers are. So that really leads into our conversation today. So, Dr. Silk, you are widely known as a non-traditional oral health provider, and hopefully we don't have to do that non-traditional leading in phrase in the future. But at one point, you were not an oral health provider. Could you tell us a little bit of your story of how you became one and how you trained yourself to become one?
Yeah, again, thanks for having me here today. And it is pretty cool to see in the chat like all the different folks that are listed as part of this oral health team. So as a family physician, you're right. I didn't think of myself that way during my training, but I quickly became aware of the need. I think that's probably step one is noticing. And so I was in Worcester, Massachusetts. We don't have fluoride in the water. We still don't have fluoride in the water. And I just saw so many children and adults with oral health issues that I was like, we need to do something about this. As a primary care provider, you can't just say like, well, this isn't my job. So I started to educate myself. But what I noticed was a lot of the ways one would educate themselves seemed to be a little higher level than what I needed. It was a lot of dental sort of literature. And so that actually led to creating some curriculum that myself and some others did geared at primary care. But I did some shadowing as well, spending some time with dentists and oral surgeons, the same way I would spend time with an orthopedic surgeon or a cardiologist. And so that really helped me to sort of understand the issues more, to understand and approach. This was, this is like 20 years ago. And then, then I actually started to create curricula so I could just teach my fellow residents, faculty. And the next thing you know, this snowballed, and we started to take this around the state and then around the country for others to learn as well. So I guess I would say recognition and then educating yourself. And nowadays, it's so much easier to educate yourself.
And when you were training yourself for the actual practical piece, were you training yourself around oral health assessments, fluoride application, all of the above? Like, what was the skill that you were looking for initially?
Yeah, that's a great question because, as a primary care doctor, I'm not trying to become an obstetrician. I'm not trying to become a dentist. I'm trying to stay in my lane. And so my lane is to be able to take a risk history, to be able to look in the mouth meaningfully, to put on a pair of gloves, to have a piece of gauze in my hand, to actually, have proper lighting, to give good advice on how to prevent disease. And then to be able to recognize when there is disease and triage it appropriately. So there may be times when I could put some fluoride varnish on some demineralization and slow the process down, but I still need to get the person to the dentist to do the definitive care. And so I think training primary care folks how to do what they can do and then know where, when, and how to refer.
Thank you for that. I'm really glad that you brought up the good lighting bit because I teach students when they first start in the clinic and just getting yourself situated in a place where you can actually see is huge. So thank you for bringing that up. So like you mentioned, once you started training others because you were already trained, you've been involved in a lot of curricula. And so I, as a dentist, I know how our curriculum is built to build that foundation of oral health and overall health knowledge. Could you tell me firstly about your involvement with Smiles for Life and any updates to the curriculum now that you'd like to share?
Yeah, so at the time, there was a number of us who were creating curricula in our own little worlds in Connecticut and Washington and around the country. And we sort of found each other. Some of that was through some HRSA funding. Some of it was through our Society of Teachers and Family Medicine. And we said, why don't we bring all these ideas together and create a curricula that others could use? So that was the origins of Smiles for Life. And like, for example, DentaQuest was there right at the beginning. And now that their CareQuest continue to support the funding, our Cora, the Connecticut Health Foundation. So people who like really, care about this topic. And now what we have is 8 core modules. And that covers the lifespan from prenatal oral health to children, to adults, to geriatrics, how to do a proper exam, et cetera. And we have a new platform. So I really want to, promote that. If you Google Smiles for Life, it'll be the first thing that pops in, and it's worth visiting. So a person can go on and for free get CME credit, CE credit. They can work their way through the modules, or as a teacher, you can download the tools and teach to others. And it comes with speaker notes and videos and all sorts of things. There's some other modules. Brittany and I were lucky enough to team up and create a global health module that's on there. There's a community health worker module. We've actually taken the modules and Canadianized them. That doesn't just mean putting a on the end of every sentence. It actually means looking at what are the fluoride sort of rules and regulations in Canada. We have questions, we have cases, we have downloadable apps. So really proud of that. As proud as I am of Smiles for Life, people should know that there's other curricula out there for primary care folks. So the American Academy of Pediatrics has Tiny Teeth, which is amazing for thinking about prenatal health in young children. And they also have the PACT curriculum, protecting all children's teeth. The AAMC, the Association of American Medical Colleges, has MedEd Portal. And years ago, there was a group of us who helped create a dental collection. And so there is a really rich curricula there as well. And then lastly, I would say that that many states have curricula. So Maine has From the First Tooth, Colorado has Cavity 3x3. These can be used in clinical setting as well.
Yeah, so you really touched upon all the different resources that are out there, and it really speaks to how much work has gone into creating these toolkits, this curricula and content to educate primary care providers and also other non-traditional oral health providers. I also want to speak about your involvement in some of the curricula that you've put together at the University of Massachusetts Medical School, and how that process has been in interacting with students. What are they asking for, and just how have you woven it throughout the curriculum to really make it a robust curriculum?
Yeah, no, thanks for asking that. We've been fortunate enough with the Center for Integration of Primary Care and Oral Health, CIPCOH, over the last 5 years with HRSA funding to really create what we think is a model curricula at UMass Medical School, now UMass Chan Medical School. And so we try to look at it from, the very basics to getting more sort of clinically competent. So all of our students now in anatomy class, for example, spend more time looking at the mouth, at the different structures, how to describe, label, how do you get the counting system down for teeth. They do a dry lab where they sit there with skulls and things. When they're in their infections course, they're learning about the bacteria in the mouth and how that affects the mouth and the body. In their cardiology course, they're thinking about inflammation of the mouth and how it affects heart disease. Some students go on to get more, so they can sign up during our population health clerkship 2 weeks. Some people do homeless health, some people do disabilities, but some people choose oral health and they spend a couple weeks like alongside providers. Our rural, urban, global pathway all have oral health components. So Brittany again has taught our global health pathway students. Students going into family medicine, emergency medicine, pediatrics will choose to do electives in oral health, and then they'll spend even more meaningful time alongside dentists. So recently we looked at this, and the AAMC has 48 oral health competencies that they list. And at our school now, we're covering 42 of them. And CIPCOH has 7 EPAs, entrustable professional activities, that Sheenam created, and our school is now covering all 7 of them. So I think we've got a really model curriculum that we'd really, we've just written this up. We really want to share this with other schools and residencies to start trying to utilize.
And I loved one of your students helped you out one summer and created a tooth map, and I absolutely love that. If you could just mention briefly what a tooth map is, I think the audience would really appreciate that.
Yeah, so we try to encourage schools where Shyam's going to get into this later, how we try to work with schools, but we try to get them to do some curricular mapping. So we say, where do you have oral health right now? So they may not even know it, but they're teaching about bacterial endocarditis. And we're like, well, why don't you put a little tooth on your curricular map? And then, as you add something for the physical exam or you add something here or there, we put little teeth all across our 4-year curricular map. So now you look at it, you're like, wow, there's teeth all over that map. Other people have done that for nutrition or topics that are near and dear to their heart, geriatrics. And so we were just sort of mimicking that to say, hey, oral health is as important as those topics.
I love that. I think it can feel really daunting if you have to include so much into a curriculum that's already jam-packed. And so feeling like actually just putting bits and pieces and weaving it through can really feel more manageable.
Yeah, let me just highlight that really quickly. because I do think it's sneaking it in, and for two reasons. One is people don't want anything more, so we would go to them and say, "Can we add 2 slides to your lecture?" But the other thing is, then the students think it's part of cardiology, part of infections, not like, "Hey, here's our oral health afternoon." So I just want to highlight that that's a really important part of this.
Just out of curiosity, are there 32 total teeth on the map?
That's great. I'm going to check. And if we only have 28, maybe the molars got pulled or the wisdom teeth got pulled or something, but I'll check. Thank you.
Wonderful. So yeah, that's a nice lead in into Dr. Tiku. In our research, we worked together and found that oral health champions really can drive change in a lot of this work, whether or not they're traditional or non-traditional oral health providers. And you've led a lot of our work and have championed our work here. And so I wanted to hear a little bit about the champions and how that turned into what we've been calling the 100 Million Mouths campaign.
Thank you so much, Dr. Zhang, for inviting me in this webinar. I am really honored because I'm surrounded by oral health champions here, including yourself. So to kind of give you background about what the 100 Million Mouth campaign is, I want to talk about CIPCOH's research, which kind of feeds into why we created this campaign. So over the last 5 years, CIPCOH has conducted systems level research to understand the integration of oral health into primary care training programs. And I just want to give an idea of what we mean by primary care training. We just don't mean family medicine. We mean internal medicine. We mean pediatrics, med peds, geriatric fellowships, OBGYN, nurse practitioners, physician assistants. So, I mean, and of course, the definition can get broader, but that's what we looked at. And our studies found that like 50% of the programs across all these disciplines, except perhaps 1 or 2, were teaching only 1 to 3 hours of oral health in their curriculum. We also found that 30% of the program directors across these disciplines agreed that they were satisfied with the competence of their graduates in oral health. So it was only 30% across all these disciplines. But one thing that we found among programs that were actually including oral health is the presence of oral health champions. So we found that one of the main predictors for integration of oral health in a primary care training program was oral health champions. And I want to kind of focus on in which ways. So programs that had oral health champions had more hours of oral health teaching. They also had, the program directors had greater satisfaction in their learners' competence, and they had formal relationships with dental schools, residencies, dental hygiene programs, so on and so forth. So we really think that, because we don't have systems-based mandates, we don't have accreditation standards within these training programs, these champions really are important to create that change. Something that Hugh has been doing and something that Hugh has just described. He is the example of that oral health champion. So we need more Hughs essentially to kind of, do this work. So we decided, because of our research, to launch the 100 Million Mouth campaign. And the premise is that we, train a set of champions, one across each of the 50 states. So we have one state education champion who will then engage primary care training programs within their states, create new champions, engage primary care training programs, and really foster change within these programs. So that is really our premise for our 100 Million Mouth campaign.
Fantastic. And I love how you were thinking big and the team was thinking big about the 100 million mouths. That's not a small number. And wow. So my understanding is that we started with a smaller group of champions, and they went through a wonderful curriculum for training and for disseminating the information. And so I would love to hear a little bit more about those 6 initial champions, that I can pull up those images in a moment.
Sure. So I need to provide some context as to why we chose the champions from the states we chose. As I told you, we are hoping to create a champion across 50 states, and you have them on your screens right now. So initially, we started off, we wanted to do a pilot. So we chose that, okay, so we need to first determine which are the states that we want to pilot this at. So we created an algorithm to rank the 50 states using metrics so our metrics were caries rate within those states, dental shortage areas within those states, whether the state has Medicaid, dental coverage, number of health professional schools with known oral health curricula, which was important, and which is this data was particularly collected during CIPCOH research. And these are some of the metrics that we, collected, and we created an algorithm. And based on this, we identified the 6 states, and these were the lowest ranked 6 states across 4 geographical regions in the country. And these states were Delaware, Tennessee, Alabama, Missouri, Iowa, and Hawaii. We, to kind of get these fantastic champions that you can see on your screen, we had to promote the opportunity. We used our, professional society listservs, professional networks, and our champions were chosen. We had a criteria for choosing these champions. We wanted to account for their prior experience in oral health, and we wanted to also look at their connection to academic programs, among other metrics. So we selected this really, really fantastic group of people that you can see on your screen right now. And as you can see, they really represent diverse disciplines. We have pediatricians here. We have internal medicine doctors, we have family physicians, we have nurse practitioners, and we have dental hygienists. So, and our champions really work within settings that we care about. They work in settings serving vulnerable people, high-risk patients, federally qualified health centers and long-term care facilities. So this really is a fantastic group of people, Dr. Jen.
Great, thank you so much. And so could you tell me a little bit about the structure of the trainings that you provided, and maybe a little sample of what went on during those sessions?
Of course, and I do want to mention that Dr. Silk is a co-lead, so he can chip in at any time. You can add if I've missed anything, Dr. Silk. But we conducted 2 2-day sessions for each for 4 hours, and what we really wanted to do within those sessions were to give our champions tools to engage with programs. And we actually had many champions, oral health champions, including Dr. Silk. We had Dr. Seymour as speakers during these 2-day sessions. We had other fantastic oral health champions, who worked in physician assistant training programs and nurse practitioner training programs. And some of the tools that we wanted to give our champions were, how do you engage with other primary care professionals? How do you make the case? And Dr. Silk actually provided that toolkit beautifully, as you can see in this webinar. He's such an eloquent speaker, but he really made that case for how you can engage primary care professionals. We gave them we collated state and national resources, and we provided that to them. So within each state, who is your Medicaid dental director? What are the coalitions working in your states? What are the dental, consumer advocacy organizations in your states? Which are the primary care training programs in your states? Which is really important, and we collated that for each state, and we provided them with those resources. We provided them with resources on, curricula and competencies. So something that Dr. Silk just mentioned, Smiles for Life curricula. We told them about ONEP curricula, the PAC curricula, the entrustable professional activities that we had created. We actually introduced them to the OGCH tool, which has been created by CIPCOH, the team as well, which is the oral health curriculum evaluation tool. You can actually use that tool to evaluate oral health curricula within your training program. And we just, gave them, we had talks from these, like I told you, fantastic champions. And we also gave them sessions on how to really evaluate their work going forward. So that was really what was in those 2-day training programs. The ultimate expectation really out of that was that going forward, they were going to then in their states engage with at least 3 primary care training programs and engage other champions. We provided mentorship throughout that process. So 6 months after the training, we would meet monthly. We would discuss challenges, have brainstorming sessions, so on and so forth. So it was a really enriching process.
Great. And what was the feedback from these champions?
We actually have a quantitative and qualitative data for that, but we conducted post-session surveys after the training, and the champions rated the sessions really highly, individual modules, the rollout of the training. They felt they were equipped and confident to go ahead and train their own champions, engage with programs. We also did qualitative interviews, and again, they were very appreciative of the whole process. And then we also, we evaluated their work as well. So we looked at how many training programs. Like we said, the expectation was 3 programs per champion, but of course, like I said, these were a fantastic group of people. So a lot of them did more than 3. We looked at the way they were, recruiting these people, their training modalities that they use, so on and so forth. So there's a lot of rich data coming out of this evaluation process.
And I wonder if part of it is also, I don't know if any of them mentioned, just being part of a collaborative or something where you can bounce ideas with people, and just having a monthly check-in, or just having that expectation so that you can really lean on each other. And we all have a lot of work on our plate, but at that structure, I wonder if that added to the experience too. Oh,
definitely. It did have it, knowing that everyone comes from, has different experience, is in different cycles in their, at different stages in their career. And they, someone brought, experience from how they were engaging with, for example, state advocacy organizations in their someone, brought experience of how they had used workshops to train, primary care, practitioners in fluoride varnish. So they all brought, their own experiences into this. And like I said, we actually had a lot of speakers, many speakers. We had oral health champions in the training process. So it really helped throughout the process, for sure.
Fantastic. And so what are the next steps for the 100 million mouths campaign?
Well, it's 100 million mouths, isn't it? but we're really hoping to have a national rollout of this, and using lessons that we have really learned from this process. We are hoping to now, in the next phase, roll this out to 8 states, hopefully, in this year. We will continue to engage our champions, that, the existing 6 champions. One of the things that we really want to focus on this year, and we implicitly focused on it last year, but I think this year we really want to focus on health equity, which will be core to the 100 million mouth campaign, and this will be reflected really in the way we select our champions. We will add modules to our training programs, and it will also be reflected in the champions scope of work. Another thing that we're really excited about is that we have formal commitments from discipline-specific professional organizations. So they will help work with us. They will help us recruit champions, help the champions engage with primary care programs, and we are also working with state and national advocacy organizations to really have, like I said, greater focus on health equity through the life cycle of the project.
Wonderful. Thank you for that. And now, growing from 100 million mouths in the US to even a global stage, I want to move to Dr. Seymour. You're a global oral health expert. And I wanted to hear a little bit about your project. You're a lead for a project with the World Health Organization on closing gaps in oral health access in Africa. So I'd love to hear about this project and how it came about.
Sure. Yeah, I was thinking the same thing, that we're moving the conversation from 100 million to 7.5 billion mouths. So it translates globally, this discussion today. I do want to take a moment and just highlight some really important and exciting kind of global forces that are provide some more context that are impacting programs and why we're having this conversation today, and that it's not just within our own kind of portfolios of work, but there's actually global recognition as to the rationale behind all of these programs we're talking about. So many of you may know that in 2015, the UN hosted the Sustainable Development Summit, and 17 global goals were signed on by every UN member state, including the United States. And goal number 3 is to achieve health and well-being for all by 2030. Easy enough. Oral health was not explicitly part of this sustainable development goal, but a lot of important global level advocacy for oral health has occurred. And I would say one of the strongest indicators that is a focus of this Sustainable Development Goal 3 is this idea of universal health coverage, meaning that all people have access to the health services they need without incurring financial hardship. And global health advocacy groups have really advocated that universal health coverage include oral health services. And what brings me to address this is that in order to have a strong universal health coverage model that requires a strong primary healthcare system. And if oral health is going to be part of a universal health coverage option for every nation, oral health must also be included in the way we think about and deliver primary healthcare at the community levels. Okay, so there's global momentum behind these ideas of, quote, non-traditional providers assisting with oral health improvement in the US and worldwide. So I always like to remind us that we are part of this global agenda underway right now, and it's just a really exciting time to be engaging in this work. So that being said, another exciting milestone that happened, all this momentum with the Sustainable Development Agenda and the integration of oral health into that agenda at the global level led to, at this year's World Health Organization General Assembly, their annual meeting, they came together and an item on the agenda was oral health, which is a really important milestone for this work. And from that agenda item came the oral health resolution, where the WHO has committed to including oral health in the global development agenda worldwide. And we all just submitted comments on a draft strategy for addressing oral health globally around the world. Part of that strategy includes training non-traditional healthcare providers to support this global momentum around oral health improvement. So I think it's really important to center this conversation around all this momentum that is happening and these historic milestones that even only this year have occurred. So that leads me to your question and the project that I have the privilege of being a part of with the World Health Organization. The Oral Health Office in the African regional offices of WHO are undertaking an important initiative where they are leveraging digital technologies and mobile technologies to support all of these initiatives underway for oral health, including addressing common risk factors for many different diseases and conditions, such as tobacco and sugar, that we know lead to periodontal disease, dental caries, oral diseases, but also cardiovascular disease and diabetes, along with many others. And these common risk factors require interprofessional and multidisciplinary teams to address those successfully and to allow us to achieve more in terms of prevention and health promotion, rather than just costly and reactionary treatment approaches for managing these. As such, because there's such a shortage of oral health care providers in the African regions, they are really encouraging leveraging both mobile and digital technologies and what we are calling today non-traditional oral health workforce to start to combine those and reach corners of that region who don't have any access to oral health care services currently. So we are creating a series of online digital training materials that can be utilized in the African region that we hope can be scaled and adapted across the world to create opportunities for training non-traditional workers. And so we are starting with the foundation of community level workers, and we will eventually and hopefully build to continue to develop further up that primary healthcare pyramid of training.
Thank you so much for that context. I know I appreciate that reminder, and there's so many pieces at play to make sure that all this important work is happening. And you and I have worked in some other global oral health projects, and you taught me that one of the first and most important things to do is your needs assessment and making sure that there's no one size fits all for global or not global curricula, right? So teaching one student, it could be very different to teaching another. And so how are you crafting with your kind of educator hat on to make sure that this really reaches the audience that you are creating this for?
So this is always a challenge when we want to create kind of public goods, open access materials that are available across a spectrum of users. How do you actually create materials that are usable across that spectrum? And that's certainly a challenge. And we're going to learn a lot through this project and this initiative. But we are taking, I think, an important approach of looking at the biomedical model for health and disease, the evidence-based model of curriculum, meaning what's the cause and effect of oral disease? What do we know causes it? How do oral diseases develop and how are they managed, right? We have a firm evidence base there. So we will rely on this biomedical model of oral health care and disease prevention. But we also are building in opportunities for a sociocultural model of delivery of this content. So we will create frameworks and guidelines, but really rely on local communities and ministries of health to adapt these materials for their context, for their setting, and for their targeted learners. So it really requires strong partnership and strong collaborations.
And I think all of us here recognize the amount of work that goes into creating these modules, but something that we've also recognized in the years of work is evaluation and follow-up and constantly improving. I know you're in the process of creating this content, but kind of thinking forward, what are you thinking in terms of making sure that you get feedback from the students and that it's, there's follow-up, so it's not just here's all this content and then just letting go, which I know you and the project leads won't do.
Yeah, so I think you've worked with me. I have a particular approach to curriculum development. It's a systematic approach that I was trained to implement and to utilize that we are employing with this project. Step one is the needs assessment. What are the needs? What are the reasons we're doing this? And how do we make sure our rationale is really based on the existing data and evidence, right? Step two is that targeted needs assessment. So now we start to narrow our focus. We have a big picture of what the needs are. Now let's target this. Who are our learners going to be? Who are our educators going to be? And then step three is, what do we want to achieve with this training program? By the end of this training program, what should the targeted learners be able to do? And really define those learning objectives clearly. From there, then we decide, okay, if they need to be able to do this, what is the best way to teach them to do this? The best setting for this, the best way to deliver the content, etc. And then we start moving into actually implementing this on a pilot level, creating those feedback loops in real time. And step 6 is working toward that longer term sustainability of this education initiative, continuing monitoring and evaluation, and building in cyclical revision and improvement of the curriculum as it continues to be rolled out. And so we have this roadmap in mind, and all of these steps are interconnected. So as we're working with our collaborators, we're piloting these in 4 countries in Africa starting next year. We're working very closely every step of the way on both these short-term deliverables and on the longer-term strategy of sustainability and monitoring and evaluation of the success of these programs.
Thank you. Yes, I think those steps those phases are really important to also kind of remember as a content creator that everything falls into place and that this can how we can really support the audience as well.
Yeah.
And so we've talked a lot about really positive and exciting and big picture items, but there are a lot of barriers as well. And so I do want to engage our audience, since I think we've had a very active chat, and I thank you, Dr. Silk, for following a lot of those. But I have a poll question here for the audience. I'm going to put up the slide first and then launch the poll. Here's the poll. So in your opinion, what is the greatest barrier to training non-traditional oral health providers? We've talked a lot about training this population here, and I'm curious our audience what we all think. A couple more seconds, and then I will turn it to our panelists to address this comment here. Share these results. Not sure if everyone on the panelists can see this, but it looks like the top is leadership, provider, and staff buy-in. But there's across the board, all of these are barriers, and we've seen this in our CIPCOH work. A lack of funding to support the training, lack of time, lack of access to training resources, and other. And it looks like we're seeing some of those typed in here. Existing dental laws, we're not allowed for non-dental providers to perform intraoral procedures, and the opposition from dentists and dental professional bodies. So, and this is to any of you who'd want to address this question here in terms of barriers.
I think I would have gone with the first two, lack of funding and lack of time. I think leadership is buying in more and more over time, and providers, they don't always have the time to do it, or they don't always know exactly what to do. But I find that they're seeing it enough in Medscape, in Up to Date, and all the things they read that oral health is important. So they're starting to buy in. As we've said, there's lots and lots of resources, and I see that others have put some in the chat today. So that's not so much an issue. I think lack of time is often a perceived thing. And when someone comes to me and says they want me to do something more in my office or in my curriculum, I first, get scared. And then I listen. And if we're weaving it in, if we're dividing and conquering, if the medical assistant is going to take the risk history and the nurse is going to apply the varnish and the doctor is going to do the exam and the front staff is going to do the referral, then the time becomes less of an issue. We do need more funding, though, if we're really going to get this going. As Sheenam talked about 100 million mouths, that goal is if all 50 states have a champion and all 50 states are engaging all primary care programs, from midwifery to physician assistants to family medicine residencies, that's going to take more funding. But if we can get that funding, and more people can get that funding, and we can get into all those programs, then I think we'll take it seriously. This idea of like laws saying that we can't do this, I don't think that's true. I think a physician is allowed to look in the mouth, a physician is allowed to biopsy in the mouth, a physician is actually allowed to extract a tooth. I'm not saying they should do that. And I don't think we actually need a system where physicians are extracting more teeth, just like I don't think we need a system where primary care doctors are taking out more gallbladders. That's not what I'm trained to do. If I lived in the middle of nowhere and I was the only provider, then I should get that training. But otherwise, we should work as a team and do what we do well, and really figure out how to divide and conquer so that we're getting the best for patients.
Thank you for the response. It actually leads to a question our audience asks here, that you mentioned that physicians should focus on oral health promotion and staying in your lane. And we did a session on our lanes. But some patients don't have access to dentists in the US and globally. So what else can trained non-dentists do to treat patients' oral health problems and relieve their suffering? It's a very important question. Thank you for that. That can go to Dr. Silk or any of you here.
I'm curious to hear from Brittany, because you live this world, right? There's never enough dentists. So what do you think?
Sure. Yeah, I was going to jump in. So same page. Because those are the questions we're tackling and what we're deciding to teach in these modules. We are targeting community health and community level workers with these modules. And within the African regional offices, those there's a lot of variation in how that's defined, but in general, they are considered well integrated members within their communities who may or may not have formal healthcare training yet. Some are paid within the workforce and some are volunteer. It very much depends on the local context. So we are working to determine what kinds of things that we will be writing into the content to address this very question. And a lot of it, we're going to really work on when they look in the mouth, what's normal and what's not normal, and then what do you do? Because the hope is, and within the US, there's been some really good work done looking at emergency room use, the use of emergency departments for oral disease. This is a global challenge. By the time a person is presenting to the emergency department, the disease has often progressed very far, it's extensive, and the treatment needed is equally as extensive and quite costly. So we see community level workers as key players in early identification, early intervention, and a really important component as a first introduction into the formal healthcare system. So whether we're doing this in Kenya or Angola or in New Hampshire, here in New England, we see these non-traditional players as really key points of contact for early identification and referral into the formal healthcare system or dental delivery system.
Yeah, thank you for that. I think that really also addresses what the work that we've been doing at CIPCOH, and now we're trying to open lots of doors and have multiple entry points into the system. As we know, access and health inequity is really a concern and something that we're trying to work towards. And so, you know, training non-traditional oral health providers is to do exactly that, like you said, just bridge the gap, open communication, and help get patients who are suffering to the right people and to the right places. I know that's a whole system in itself to navigate that, but if we can assist in making that smoother, I think that's kind of the goal that we're trying to go after. I did want to ask Dr. Tiku, so I think there's a lot of interest and curiosity of how we get to that 100 million mouths, and we started with 6 and how we're expanding. So one is if you're able to share with us the 8 states that are coming up next, and also how people who are interested can apply for future steps in this campaign.
As Hugh just mentioned, that everything is, you know, dependent on, you know, dollar signs. So, but having said that, we do have some states that we have kind of shortlisted. Some of, you know, one of which is New Jersey. I have a list of other states, but you know, I think in hopefully in the next 2 weeks we can be a little more clear about how the, you know, interested parties can then contact us, and we will actually make this information available on our website, and we will reach out through, you know, various listservs and professional organizations as well.
And so I do want to take a look and see if there are other questions. Feel free to continue typing in the chat here. You know, we at CIPCOH, we are hoping to take a systems approach in addressing this health inequity, and also increasing the training and research and dissemination of the community practice that is out there from a local to national to global stage. And while those questions are coming in, I did want to share, we talked about a lot of resources that we threw out there really fast, and I know we've been typing into the chat. But I did want to share here. This is our CIPCOH team here. Everyone has really contributed a lot to our projects, and moving forward, we really have a robust plan moving forward, and a lot of individual collaborators as well listed here. And you can see our website down below. And some of the resources I wanted to share here, I'll hover over this next slide a little bit longer here, is the resource library for integration of oral health and medicine. And we're trying to update that and keep it dynamic. And you can find also the integration stakeholders. That's actually national. And so I will have to work with Dr. Seymour and add that on the map to make it more global, because we are there and we are moving in that direction. And media pieces also, just like our webinars here, are included on this resource. And some resources here from Smiles for Life. And like I mentioned at the bottom here, the CIPCOH website. Are there other resources and websites that just off the top of your head that really just share what we've talked about here today? I wanted to ask the panelists.
I think sometimes when you go to these websites, there's also links to other websites. And again, I think, highlighting the American Academy of Family Physicians, has a section on oral health and many oral health tools. I think it depends what you're looking for. ONEP, OHNEP is nurse practitioners and their trainings. PAEA is the physician assistant organization that also does a lot of oral health training. I think if you're looking for patient resources, I like myteeth.org, mouthhealthy.org for ADA. So there's so many different sites and resources.
I can also include a link to our online curriculum, the Global Health Starter Kit, that is based on the courses we've developed for our dental students that we've now expanded to residents and college students here. But we've created an online open access version of that curriculum that takes that global perspective and brings together global policy and human health and development, and where oral health and oral health care delivery fit within that. So I will include that link in the chat.
I just want to mention again, a toolkit created by Hugh and Judy Savageau at UMass is Oral Health Curriculum Evaluation Tool, which is an excellent tool that programs can actually use, and then they can quantify the amount of oral health that they actually include in their program, which I think is really helpful. It's the first step to understand what you need to include. And it's an excellent needs assessment tool, really. It's been published recently in the Journal of Dental Education. So that's something we would love to share as well.
Thank you. I see a participant has a raised hand. I don't believe in this setting that we can put you on, but please type in the chat. We have a few minutes. We'd love to answer your question. As we're waiting for that to come, and I did want to mention one thing here, circling back to our first poll question, just thinking about that non-traditional oral health provider here, I'd love for a wish list of who our next non-traditional oral health provider we'd like to reach out to. I know in some of our research and looking at interprofessional providers in our early years of CIPCOH, we were looking and saw that medical students, pharmacy students, and nursing students were really quote unquote popular in terms of students of non-traditional oral health providers. But at the bottom, there were law students and podiatry that I think would be phenomenal. And kind of my wish list is to really reach out as far as possible. Physical therapy is something that's new that I hadn't worked with in dentistry. And so I'd like to twist this back to you all and see kind of a wish list and an action item, perhaps, and someone that you can bring to the table in your discussion in future oral health training. And the panelists, if you have any last thoughts, 1 minute takeaways, or if you see a question in the chat that I have not addressed, please speak up. Librarians, thank you. I love that in there. Thank you so much, Dr. Bass.
I think we probably, don't think enough, but this has come up in some settings, in Head Start. There are different people, doing education there at WIC. We talk about community health workers, but like just thinking about the case managers and social workers who actually help get people into the dental chair. Medical assistants obviously are playing a huge role now in the states where they're allowed to do fluoride varnish and look in the mouth. And all of that, the front staff of an office, literally as a team approach to making those referrals. So, gosh, it's kind of endless, isn't it?
I see that Christina has brought in Dr. Brennan. Dr. Brennan, I see your hand. I welcome your question. If you're still on mute, I'm not sure if you still have your question. I know that hand sometimes stays there.
I don't know if he's going to get on. I see Lamaze instructors on the list. There's a program called Centering for Pregnancy, which teaches how to do group visits for pregnancy. I've been a part of that in the past, and they have added an oral health component. This is a national curriculum called Centering. And so every woman during their prenatal sort of training and thinking about how they're going to deliver and all that learns about the importance of oral health. So that's very cool that national sort of model for prenatal care is doing that.
Dr. Silk, I think you like you said, it's far reaching. If I had to ask you a wish list of a non-traditional, I think you'd be kind of out here. So I'm actually curious who's on your wish list.
I'm curious again with Dr. Seymour, and like again, you have to be incredibly creative. I guess if I had to add, like pharmacists are already part of this, but I do wish that all pharmacists, were sort of like saying, hey, do you know that's going to dry out your mouth? And have you thought about this? Or call the physician and say, do you know that's going to dry out your patient's mouth? Could you lower the dose or try something else? So probably just taking some of those team members that are getting into this and having them do more.
I'll close with Dr. Teaker, Dr. Seaman. Do you have a wish list on your next non-traditional oral health provider?
I think we've covered most of what I mean. I don't think about Lamaze instructors, but that's such an excellent suggestion. And I just want to point out, I think Jane Barrow in the chat said public health advocates who, I think that's so important also to include in that wish list.
Yeah, I would double down on that the most prevalent oral diseases we're managing are actually quite preventable. So having much stronger foundations of cadres of workforce who can assist with these methods of prevention will really shift what the burden of disease looks like and the distribution of the workforce and how we handle that.
Thank you. Well, thank you all, Dr. Silk, Seymour, and TQ. I really appreciate your expertise in coming together today. We are actually in one building, but our bobbing heads are virtually in different spaces. But thank you all. And I want to close with, like I said, going back to that poll question, really, we can reach out to a lot of people as advocates ourselves, and not only for oral health providers, but also oral health advocates. And I would say, for example, someone in media, I just had a conversation the other day of people asking just about how oral disease occurs and how we can share that with the general population. So really, there's a lot of work that we can do. Thank you all for your time today, and we look forward to future collaborations. Reach out to us with any questions, and hopefully we'll see you in the future. Thank you.
Thank you so much.
Thank you.